And also, fewer of them were below the 10th percentile in height, and that was sustained over time. And the interesting thing was the height differences in patients identified after the fact were sustained over time. So we were producing children with lower BMIs who were shorter, and we know now that affected their lung function. So as a result of this paper, the recommendations were made that we did neonatal screening. They took this as evidence, very strong evidence, that we should have national neonatal screening, and the recommendations came out in 2001. Maine is a wonderful state. It was my home state, as you guys know, but we adopted neonatal screening here in July 1st of 2008. So occasionally we see children who are born before that we're identifying based on their symptoms who have cystic fibrosis. So what do we do about it? So now we know how to screen it. We did the neonatal screening, so what else do we do? High fat, high calorie diet, you all know that, but why? Why does that make a difference? Part of it is that we know that the defect in CF is enzymes that digest fat, and that if we can get normal growth, it's associated with increased survival. So there was a couple, these are old papers, because this is one of the first things that was worked on. There was a paper in 1985, and I promise you the slides get more exciting. So as the papers get newer, they're better figures. So in 1985, this is a group, and this is before newborn screening and before the gene for CF was discovered, that looked at long-term nutritional rehabilitation on body composition. So what does all that mean? And also on their lung function. What does all that mean? It means a G-tube, essentially. So they had 14 patients with CF. Remember, the reason I showed the numbers, a lot of these studies don't use a lot of patients because it's not a common disease. 14 patients with CF between the ages of 5 and 22. They had moderate to severe lung disease, which to a pulmonologist means their FEV1% predicted. That number that sometimes we focus on very closely was between 35 and 70. They had malnutrition, they had growth failure, and the follow-up time for this study was around 1 year. So their intervention was nocturnal G-tube feeding. And what were the results? So they had a group that they did not do this with that was retrospectively identified because they didn't feel like it was okay not to feed a group that looked like they needed to be fed. And fair enough, right? And then they had the group where they did the nutritional. And for weight, they found that they could increase their weight by 2% a year in children who had growth failure. The interesting thing is that the control group didn't sustain their weight, but they continued to decline by 3% a year. And as I said, the continuous loss in weight is associated with decreased survival and decreased lung function. For the pulmonary function, which is obviously what we focus on as pulmonologists, they found that the nutritional group had no significant change in their FEV1 at all, which at first maybe seemed kind of like a bummer, but in the control group where they didn't get nutrition, they had ongoing FEV1 decline by 13% a year. So that's quite a gain, actually. And this is part of the data for why we talk to people about supplemental nutrition, and why if we can't keep up by mouth, which can be really hard to do for kids, I think those of you, any of you who have children that have trouble with that know that, why we move to a G-tube to sort of take the stress out of eating for children and for families. We like to have mealtime as a social time because in this country that tends to be what it is. And if we can remove the stress, sometimes it removes a lot of stress from the household. So this is an earlier paper, and I kind of put them in reverse order because I wanted to talk about the G-tubes first. But this was a paper in 1980. They had 12 patients, so again, a rare disease, between the ages of 6 months and 11 years. And they studied them 6 months before a nutritional intervention and 6 months after a nutritional intervention with supplemental nutrition. 6 months prior to the intervention, there was inadequate growth and weight gain. They had 21 active infections in 12 patients for over 6 months. That's pretty high frequency. We're talking young children here. Granted, it was 1980, and some of the care wasn't the same in 1980, but that's a lot of infections. They had inadequate oral intake too, inadequate calories. So they did nutritional therapy for 21 days, hypercaloric intake with supplemental nutrition. It was a variety of ways. Some of them got G-tubes, some of them got NG tubes, some of them could drink by mouth if they could keep up with it, but it was a very well-prescribed regimen. And then they followed them up 6 months after that nutrition. So catch-up weight gain occurred by 1 month and was sustained throughout the course post-intervention. Catch-up linear growth occurred by 3 months and was sustained. So again, at that time they were just focusing on growth. Now we know that's associated with survival. They only had 3 active pulmonary infections after the nutritional intervention, compared to 21 before. And then they've also found sustained improved spontaneous nutritional intake and pulmonary function. And there were some quality of life measures I left off here, but there's a standardized forms for quality of life in cystic fibrosis that many of you may have used before, but they found improved quality of life and improved daily activities as well. So by bringing your nutrition up, not only do we get these markers of growth that we know are surrogates for health and survival, but we're getting fewer exacerbations, we're getting improved spontaneous intake, maybe because people are just feeling better because they have their weight on, and improved pulmonary function. So that's essentially the data behind why we harp on nutrition, calories, why we have the nutritionist in clinic with us. We do a lot of other interventions. We use digestive enzymes. I'm not going to go into all the data on that. But suffice it to say, if your body doesn't make the enzymes, you can't digest it. And I think this is one of the more immediate feedbacks that children and people get with CF. If you don't take your enzymes, you have a consequence typically, and it's not pleasant. So people usually take them. We take vitamins because the soluble fat vitamins of A, D, E, and K here are deficient because you can't digest fat without the enzymes. And so we monitor these levels at your visits. And then the other thing I wanted to talk about was zinc, and this is something that I have to say that it's not always forefront on my mind, although every time I read about it, I think it should be. So this is obviously a mineral, and it's affected by fat malabsorption. And the symptoms, and some of these may sound familiar from time to time for some people, include growth failure, lack of appetite, and alterations in taste. So kids aren't eating because things don't taste great, right? It's hard to screen for, and sometimes it just warrants a 6-month trial of zinc supplementation to get kids better. And finally, diabetes. Diabetes is a 5-hour talk in and of itself. I'm not going to go into that as much. But when the pancreas starts to get more and more damaged, not only do you have trouble producing the enzymes that digest food, but you end up having trouble producing insulin that helps the body process glucose. This is data, this is fresh data. This is the most recent published data on the CF Foundation website on percent predicted FEV1 versus BMI percentile. And so this is some of the associations we're talking about. Now, you could argue that as FEV1 declines, BMI declines because there's increased nutritional need, but there are additional studies that I'm not going to go into that showed that it was actually independent, and that if you preserve BMI, you will preserve FEV1. So, but this is the data. So as BMI increases, yeah.
Can you just explain how that relates to nutrition?
Yes, absolutely. So our goal, and the goal we talk to you about in clinic all the time, is a BMI percentile of the 50th percentile. And when you look here, FEV1 percent predicted, and this is all people in the registry, if your BMI percentile is greater than 50, you have a better chance, this is a mean average, of having your FEV1 percent predicted over 90, okay? Now, there have been a lot of studies trying to figure out why. Part of it is they think it's the catabolic rate of your body, so if you're having trouble keeping on calories, using more energy to grow, and less energy to fight infections. No one actually really knows, but we know that if we keep you above 50, we have a better chance of keeping your FEV1 above 90. And that can be hard for kids with CF because a lot of the calories that we're looking at come from fat, and that's where the deficits are. I'll share a little bit of data on sort of the progress of research within cystic fibrosis, and what I think is a hopeful recent publications at the end. So what other things does it encounter? Reproductive systems, sinuses, and lungs. I'm actually going to spend the majority of the time talking about lungs because it seems to be what most of the focus is. It's the main determinant of morbidity and mortality in children. So on the left is a normal lung, and on the right is bronchiectasis in a CF lung. And this is what we're trying to prevent. This is quite widespread bronchiectasis. You can find a lot of different images of bronchiectasis online. How do we get there from here? So I'm in Maine, so I get to use this sign and people know what it is. I used to put this up in Cincinnati and people didn't understand it. It was my inside joke, but most of you have seen this in the state. So how do we get from a normal lung to a bronchiectasis? Basically, what happens is this is a normal lung and this is a mucus level, and it's well hydrated. There's normal salt and water balance. With CF, you get thick mucus. And there's some, this is an area of CF research that's sort of migrating over time where this comes from, but I'm going to simplify it and say your mucus gets thicker, harder to pass, the cilia stop functioning. So the step one is the mucus thickening. As a result, the cilia are not effective, clearance of mucus is inhibited. Step two, the thicker mucus blocks your airways. So this is a normal airway here. Here's some normal mucus. Here's some thicker mucus, starts blocking the airway, and that's a problem for your body. Your body does not want a blocked airway. So it starts remodeling your airway. When it remodels your airway, those airways get big, and they get dilated, and they don't function well, and they fill with mucus, and you get inflammation. And that inflammation, and it may block that airway, and then the airway further down remodels and gets bigger, and then the airway further down remodels and gets bigger, and that's setting up bronchiectasis, and it sets up retention of mucus, and it sets up chronic inflammation, and it sets up bacterial colonization and infection, and it sets up this vicious cycle of bronchiectasis. So you get your obstruction, you get your bronchiectasis, you get mucus filling, you get infection, you get inflammation, you get more obstruction. And this is what we're trying to fight with CF, and this is why we recommend the treatments we recommend. These are just the different kinds of bronchiectasis that you can get in a lung. So what do we do about it? We make clearance better, right? This is the US. We make things better when they're bad, right? It's one of my favorite iconic pictures in the history of US and we can do it attitude. But so how do we make it better? We have all kinds of devices, and some of them are around the room right now. So the first thing, and these are organized by age actually, is manual CPT, and you all have been through this at times. Second thing is vest, and this is sort of the mainstay in the United States. In the United States is vest. Other countries lean on this a little less heavily. There are a lot of reasons why, and that's, again, a talk in and of itself. This is one of my favorites, and I use this with little kids all the time in the hospital. This is Bubble Pep, and it's essentially you fill a tub with soapy water, put a tube in it and a cup, and you tell them to make a volcano. And it provides a positive pressure when they're blowing through the water, and as those bubbles pop, it oscillates over that, and it can clear their secretions out. This is a PEP mask, which is portable. It's on the older end of the spectrum, so we're marching up in age. Because you need to participate in this, you need to be mature enough to do it. You need to sustain 20 minutes of effort for it to be good. Acapella, the pickle. Everybody's probably had one of these in their house at some point and used it. Aerobica, this is infiltrating our unit right now. I like it. It's interesting. You can pump nebulized meds through it and maybe get a little more delivery of nebulized meds. IPV, which I love, actually. And again, there's some open debate about this, but IPV is intermittent positive pressure, so it pumps air into your lungs over and over and over again. Your lungs see pretty high pressures with this, but the idea is it inflates your lungs a little bit with pressure, oscillates pressure over it. That air gets behind the mucus and helps you clear it out. It vibrates you from the inside instead of the outside. It's very good in kids who have trouble with the vest because of G-tubes, big livers, abdominal distension, pain. We used it a lot in Cincinnati for kids with complications like that. This is the in-house unit, the Metanib. I will tell you there are dozens, if not hundreds of papers on comparative effectiveness. And various papers will show various comparative effectiveness of these. So it's hard to know what to make of it. And they did a Cochrane review, and I'm going to talk about a Cochrane review, which is when a bunch of people sit in a room, pull all the papers on a subject, look over them, and decide what the real answer is. And the real answer for comparative effectiveness is there's no strong recommendation of one over another. So I'm not going to get into that data. But I am going to ask the simple question, does chest physiotherapy compared to no chest physiotherapy make a difference for kids with cystic fibrosis? So Cochrane review, they looked at 144 studies, and it's pretty rigorous. You have to meet the scientific criteria of a valid study, controlled, that no confounders to make the study not worthwhile. And of those 144 studies, there were 8 that met that criteria. 94% of the studies were not trustworthy. And that's another thing we're working with CF because of some of the outcomes we look at. And I'll talk about that a little bit at the end as well. So of those 8 studies, this 4% of the studies that were published, there were 96 separate participants in those studies. the different protocols they had: autogenic drainage, chest physiotherapy, oscillating positive expiratory pressure, positive expiratory pressure, and one high pressure positive expiratory pressure, which I think is code for IPV. Essentially, this is a lot of data, but essentially what they found is that one of the 5 studies that measured, actually weighed the sputum that you produced. One of the 5 studies found there was no difference in what you used, whether you did it or didn't do it. 4 of the studies found that there was a difference, and that any chest therapy you used would produce more mucus. 5 studies used a radioactive tracer, so they'd have you breathe something in, label the mucus in your body, and measure how you eliminated that radioactive tracer. 3 of those showed that CPT increased clearance with CPT and cough compared to the control. One study demonstrated that increased clearance with any physical therapy, so they used a bunch of them, was better than control, and 1 study reported no difference. 4 studies used pulmonary function testing. Now, pulmonary function testing is awesome in pulmonary medicine. It's also very difficult because of the number of variations in what you get for pulmonary function testing, and it's not a linear scale, and I don't think we all fully understand where you are on the scale and how fast you should change. But 3 of the studies reported no significant difference in pulmonary function testing. 1 study reported improvement in pulmonary function testing. The other problem with pulmonary function testing is it changes slowly over time, and these studies are time limited, and because patients age, and you have to keep them engaged. And so while we use them a lot, it's a hard thing to study in CF. So what are the conclusions of the review? The short-term effects of airway clearance are well established. You will increase mucus transport. Longer-term effects, increases in PFTs, are not well established, probably as a function of the PFT. So actually, I usually track my time, and I don't know how I'm doing on time, but I can pick it up a little bit. So what are some other studies? If we can make clearance better, can we thin the mucus? And we can. I think we can make clearance better. I think the data's there. But can we thin the mucus? So 2 attempted techniques. One is to provide more water to the mucus. Maybe you can thin it out if you bring more water in. And one is to digest the mucus because it contains DNA. So this is the study with hypertonic saline. This stems from Australia, where some of the Australian docs were like, hey, we have a group of kids with CF who surf, and they don't get exacerbations as frequently as the kids who don't surf. So why don't we try something? And so they tried hypertonic saline. They theorized that it was the salt water they were breathing in, it was thinning their mucus. This is actually, if you Google search surfing and CF, this little girl's blog comes up, and her mom taught her how to surf when she learned the connection between surfing and CF, which we may do in this state, actually. More coming. There's a woman on the coast who takes kids with medical needs and teaches them how to surf. It's a cool program. We're trying to arrange it for CF. Yeah?
Sorry to interrupt you.
Yeah.
We actually have live streamers, and they're saying that they can hear better if you use the mic there. So
I'll use the mic here. No, it's not. No. Yeah, it's more useful if I use that. So welcome live streamers. Okay. So in the quinine was put here to remind me of something too. So in this study, 164 patients greater than 6 years of age, and I'll tell you, they use greater than 6 years of age because you can't do reliable PFTs in under 6. And that's another problem with CF research, is most of our recommendations are for ages 6 and older because that's where the studies are. It's not that it won't help kids under 6, it's that we can't study in kids under 6. And you'll hear that in clinic sometimes if you have children with who are under 6 when we talk to you. So they did hypertonic saline twice a day for 48 weeks. They inhaled 4 mils of 7% saline or 4 mils of normal saline, 0.9% saline. Obviously, you can tell the difference, but they put basically soda water in it, quinine, the same thing that's in soda water, to disguise the taste. So they didn't say whether they included a olive or anything with that. But so what did they find? So on top here, this is absolute change in FVC, or the amount of air that you can get out of that we can measure in your lungs. And they found that with hypertonic saline, they're measuring more air in your lungs, essentially. And this is over 48 weeks. This is FEV1, and this is what we talked to you about in clinic. This is what we use as a measure of obstruction. And they found that over 48 weeks, they had an increase in a sustained increase in FEV1 over normal saline. So people were pretty excited about that. This is just demonstrating the same thing. This is interesting. These are survival curves, and this is how we track events. So as you step down, you've had an event, okay? These were used to track death rates initially, but this is an event related to an exacerbation. So every time a patient in the group has an exacerbation, the group gets smaller, all right? So if you were on the control, normal saline, at 48 weeks, only 62% of that population were exacerbation-free. 76% of the hypertonic saline were exacerbation-free. That's a pretty good improvement. I'd take that. And it probably points towards the cost effectiveness of this treatment as well. Survival-free of symptom-defined exacerbations. So these were hospitalizations. These were symptoms of exacerbations, increased cough. Only 16% of the population in the controls had a symptom-defined exacerbation, 41% of the hypertonic saline. So in my mind, this is, well, not just in my mind, this is the evidence for why we recommend hypertonic saline. Now, there are adverse reactions, and you all are aware of this. You've seen it in your children. I've heard the stories. It causes you to cough. Maybe not a bad thing. We want you to cough. We want you to bring up mucus. Causes chest tightness. That's why we advocate using albuterol first. It can set off hyperactivity of your airways. So you use albuterol first to prevent that from happening. It causes a sore throat. I can't do anything about that. That stinks. I'm sorry. And I don't say that flippantly. It's a serious thing, and it gets in the way of being able to do this. Hemoptysis, and we know it causes that, so if kids start bleeding, we stop the therapy. Sinusitis, that's just probably an extension of the pharyngitis, honestly. Sneezing, it causes sneezing, and then vomiting. And again, that's something, vomiting, it can be quite serious. I met a child who projectile vomited every time they did it. So we stopped. So what else can we do? Can we digest the mucus? DNase, and that's what we tried. So we know that CF mucus has a high proportion of white blood cells, and that when those white blood cells die, their DNA sits around in the mucus. The picture on the right is what mucus looks like when we isolate it in a lab. That's how sticky it is. So this is just a little glass ball, and here's the DNA clinging on for dear life. Okay, it's sticky. It fills a vessel. It does not want to leave the vessel, including your airways. So can we digest that? In the lab, we use something called DNase. So people tried it in people. And so here's the initial trial. This is recombinant DNase, twice daily, once daily, in placebo, and tracking, again, this is a survival curve, proportion free of exacerbations over time. And you can see this is the control group. At the end of the 150 days, they had significantly fewer people who were free of exacerbation over the other two groups. Then they looked at percent change in FEV1 from baseline. When people started using DNase, they had an initial bump in their FEV1, and that was sustained over time compared to people who didn't. These were about 1,000 patients between the ages of 5 and 23. So that's the initial paper in 1994 that recommended DNase. There was a 2-year randomized placebo-controlled trial of Dornase alpha in young patients, and this is similar. I'm just sort of adding a little more fire to the fuel, or vice versa. So this was 474 patients that they started off with, and this is DNase over time as well. And so here you see 96 weeks DNase, a change in FEV1 for baseline. You get that initial bump, and it's sustained, and then it drops down, right? However, if you're on a control, you're dropping down even lower, right? So we can hold lung function with DNase. Here's FEF2575. This is something we don't talk about very much. It's hard to digest. We think it represents small airway disease, but it's more technique dependent, I feel, than any other thing I interpret on a PFT. But we're seeing a sustained improvement in that as well. And then here's exacerbation, time to free of exacerbations. So in the placebo group, you can see there are many fewer people in that group who are free of exacerbations over those in DNase. So those are just 2 trials. If you search DNase and CF in the PubMed database where we store our studies, you'll get thousands of trials. Not all of them good, but this is the data we use to recommend these treatments. So what are the adverse reactions? Chest pain, conjunctivitis, laryngitis, pharyngitis, rash, and voice alteration were all tracked. The only thing that we had a greater incidence of in DNase, and the use of DNase was a rash. Everything else was equivalent or worse with placebo. So we make clearance better. Yes, we did it, right? We thin the mucus. We use 2 different meds to make it, to digest it, to make it thinner, to help you get it out. Can we prevent or treat inflammation? And how am I doing on time? Because I can. Perfect. All right. So this is something that many of you have heard us push for in the past couple years here in ibuprofen. It's actually been around for a while. I was trying to find the survival data from the CF meeting 2 years ago, because that, I think, is the most impressive data, and I couldn't find the curve to present. But this is one of the papers on use of ibuprofen. So as you recall, in this cycle here, one of the things is inflammation. And so there are some meds we all use every day. Well, hopefully not every day, but all of us will use at one point in our life to cut down on inflammation, ibuprofen being one of the simplest ones. And so people tried that, and they tried it in kids with CF, hoping to cut down on inflammation in their lungs, to break this cycle, right? It's all about breaking the cycle of formation of bronchiectasis and preserving lung function. So in this paper, they had groups of patients they treated with ibuprofen and groups of patients they treated with placebo. And this is change in FEV1 percent predicted over time. The control group are the triangles, and the ibuprofen group are the circles. And you can see over a period of 5 years, we had a slower decline in FEV1 than we did without ibuprofen. There was some pushback against ibuprofen in this country because of the side effects from ibuprofen, which are very real, and something, if you're on ibuprofen, if we don't ask you about it, you should ask us in clinic, why didn't you ask me about this? So you can get belly aches, which can be a sign of gastric bleeding. You can get gastric bleeding, which can be a sign of gastric bleeding, and that looks like throwing up blood or having black tarry stools. Those are the big ones we worry about. There are other sort of lesser side effects. Gastritis itself without gastric bleeding can be a problem. Anybody who's taken naproxen for a long time for a sore knee or something has experienced that. And that can be an issue because we already have trouble digesting things, and we already have trouble keeping up with calories, and we don't want to add, we don't want to have more complications with that. The data I was looking for was the data presented at the CF conference in 2012, and there's a group out of, and this is why they're pushing more in this clinic meaning Portland right now, for the use of ibuprofen in kids. There's a gentleman out of Cleveland who is showing data on survival, and so he showed an improved survival with people using ibuprofen over time. There aren't a lot of treatments we can use to demonstrate improved survival. We have all these surrogates for survival of FEV1. So it was an impressive amount of data. I think it made people wake up to say, yes, we have side effects, but we can track those side effects, stop it on people who don't tolerate it, and those that do tolerate it, it might benefit them over time. And so you'll hear us talking about ibuprofen more and more over time. But there are other things we use to cut inflammation, and many of your children and many of you are probably on azithromycin. So this is one of the trials, and I love these designs because the children, wow, that's louder. That's good. I love this design because the children act as their own control group. And so this is a crossover design. And just to explain this, you have a group of kids, and for the first part of the trial, half the kids take the azithromycin, half the kids take placebo. Then you have a washout period of a couple months where nobody's taking anything, and you get it out of their system. And then they swap, and the half that weren't taking the drug start taking the drug, and the half that were taking the drug start taking the placebo. And so what do they find? So, and this gets confusing because I'm going to be jumping back and forth between the groups. But again, boring people get a kick out of this. This is the change in FEV1 over time. So this first line, the black one, is the placebo group first. So you can see in the first treatment period when they were taking the placebo, their FEV1 had a little bump. And sometimes you see this in research, and it's because Big Brother's watching, right? And so you have to go see your doctor, and your doctor asks you once a week, once every 2 weeks, hey, are you doing your clearance twice a day? hey, are you taking this twice a day? Hey, are you doing that once a day? And it's not, everyone argues about why compliance is better. I think it's just a reminder. So if you had a bug in your pocket that was saying, hey, have you done this? Hey, have you done that? You do it. And so I talk to teenagers about using their phone to do that.